Primary care innovation doesn't work. Here's why. So this is an article that I came across on Twitter. It was making the rounds on a lot of social media, and I just thought I would go through this article live, just see what it's all about. So investors have deployed over 100 billion into healthcare, digital health specifically, since 2010. But not a single generational company has come out of it. Almost every industry has birthed a 100 billion company, but digital health. Now, out the bat, I want to see, okay, what's something like Epic Systems worth? Epic Systems um, net worth. I mean, market cap would probably be a better. Okay, here we go. So Judy Faulkner is estimated to be around 45 billion. Okay, so again, revenue is 4.9 billion, and again, this is pretty consistent for a tech company because you usually multiply the annual revenue by around 10, and you get the valuation of 45 billion. All right, that's cool. Now to give you some context, okay, so 100 billion, so that's like Epic is worth half of that. Now, if we take a look at something more, let's say like KP, right, like Kaiser Permanente. So Kaiser Permanente is, again, so the operating revenue is at 100 billion. But again, for a company like Kaiser, it's not a tech first company. So, you got to think of it more like 1x, 2x multiples. So definitely like Kaiser Permanente is probably worth 100 billion, right? So, all right, going on. Over the next several weeks, I'm going to unpack why. I'm just going to read this article. I don't know what he's going to talk about in the next weeks. But okay, primary care, your family doctor slash GP. Many of the world's smartest companies are trying to own primary care. Amazon, CVS, Walmart, to name a few. The idea is that once you own primary care, you can control downstream health expenditures. So again, the idea here is, especially Amazon, CVS, I mean, what we are seeing is that they have like someone sitting alongside the pharmacy and they are just able to do these quick things. So they have like a list of conditions that they can kind of treat, and they'll just like immediately sell you products that you can take back home, like over the counter, simple. But I wouldn't really call that primary care. So, I mean, I think primary care is probably a little bit more than just, those list of those conditions that they treat really well. But okay, at the same time, many individuals are wanting to improve primary care. I've heard at least 10 friends tell me that they want to start a company in this space. I mean, he has a network of friends who are definitely like in the startup ecosystem probably. But yeah, I think this is quite the same. Like I'm seeing a lot of people in MySpace start innovating in primary health as well, because they are like, okay, that's where it's easiest to get started. All right, so this article is also for them and anyone else exploring primary care as a business. Today, I'll summarize the challenges with the 4 models of primary care innovation. So the first one is virtual and hybrid fee-for-service care. Okay, so I like that he's talking about like fee-for-service, value-based care, etc. If you should read the innovator's prescription if you haven't already, by the way. Which is not economical. Okay, so virtual and hybrid fee-for-service care, which is not economical. Virtual and hybrid. Okay, so he's talking about both talking to a doctor on a video call as well as going in person and visiting them. All right, cool. This is not economical. All right, because the fee-for-service model only works when you have more expensive procedures. So for example, if you go with chest pain, there is only so much primary care physician can do, and then they have to refer you to a cardiology center where they then make most of that revenue, right? Leading to membership based direct primary care, which was too expensive for customers, leading to reimbursed value based care, which was not scalable, leading to AI-powered primary care, which is trying to optimize the wrong thing. Okay. Okay, the first thing is like, I want to see what the wrong thing here is. But okay, let's go with the article one by one. All right. So The four stages of primary care: virtual and hybrid fee-for-service care. Okay, Teladoc, One Medical, Amwell, Carbon Health. All right. So Teladoc is off 90% since Feb 2021. I don't even know if they're still in business. This is we are reading this in 2024. One Medical was okay. Everybody is doing poorly. Everybody is doing badly. Okay, Amwell is off 90%. There is another one, right? Babylon Health went bankrupt, bust altogether. But I think they were not really tackling the same virtual hybrid fee for service care. I think they were doing a lot more. These companies have struggled for several reasons. Diseconomics of scale at the gross profit line. Okay. Virtual first fee for service care has struggled to expand gross margins. This is because the companies compete on either access, B, quality, or C, price, which are all inimical to unit economics. Inimical, what is, I really don't know. Inimical, tending to obstruct or harm. Okay, which is like kind of, it's not good for unit economics. Cool. When competing on access, you have to operate with a surplus of doctors to meet spikes in patient demand, which worsens gross margin. Yep, I guess you have to have a lot of doctors on your payroll, and a lot of people like really don't hire these doctors full time. They are sort of part-time employees who work for multiple of these startups. When competing on quality, the key was to let doctors spend more time with patients. Okay, so moving from 30 patients per day to 15 patients per day helped with customer acquisition, retention, and engagement, but also ate into economics. Obviously, I mean, you can't do more patients per day, so you're going to lose out on that money. All right. So when competing on price, you charge less per member, but clinician salaries are fixed, which is you're going to compress gross margins. All right. So the argument here is that you got to pay the clinician a fixed salary. If you're competing on price, you're just like charging less per member, which is basically at the end of the day, you're using your VC funded money to give money at a discount, right? Like you have this clinician salary, which is fixed, but then you are kind of giving away free consults or almost close to free consults to a lot of people. It's not sustainable. So inverse operating leverage at the EBITDA line. Yes. So EBTD, this one for those who don't know, it's kind of just the gross profits before, you know what, I'm just going to Google it again. So it's the earnings before interest, tax, depreciation, and so on. So, okay, it's alternative measure of profitability to net income. So this is earnings before interest, tax, depreciation, amortization. But then there is a weird way in which they kind of add amortization back in. So it's like, it's a weird formula. But you can just think of this as profit or, like net income. All right, back. Virtual first care companies haven't improved margins at the operating profit line. In fact, they haven't even improved incremental margins. In many cases, we've seen inverse operating leverage. So it's a link. Where does this go? One Medical, one step from failure. Oh God. Okay. This is an article for another day. I'm not gonna dive into this right now. So this means that as revenue has increased, costs have increased, but not just in absolute terms, but also as a percentage of revenue. Crazy. So again, this is where we are seeing, the more you do volume, the more volume you have. When economics of scale work out well, you tend to reduce the percentage of your total revenue that you spend on all of your expenses. But this, again, you have an inverse operating leverage where like the more people you have to deal with, the worse the ratio is, right? Like I can think, so again, he's explaining why this is the case. It's because unlike your old-fashioned primary care clinics, tech-enabled clinics have two entirely new line items, which are zero-sum and commoditized. Okay. First, sales and marketing, which is zero-sum because many digital health companies fight over the same customers. While paid marketing might initially work, it has diminishing returns in the margin as there are only so many early adopters. Okay. So there are a there are these initial group of customers who are all like pro digital health. So you're kind of like competing against the same pool. So the second line item was R&D. However, all digital health players spend money on the same tools. Therefore, R&D spend generated limited alpha. It was also commoditized. Okay, so this alpha here is basically how you differentiate yourself from your competitor. And again, like if the people are doing the same stuff, then they're going to get the same results. All right. Primary care is loss leading in the US. 75% of health networks operate their primary care business at a loss. Now, this is not surprising to me at all. Like coming from a healthcare background and coming from a clinical background, this is obvious. In fact, most of the times, all outpatient encounters are loss leading, right? Like, so for example, we own a ophthalmology unit, and you don't make money off the visits or the consultation. You make money out of the procedures. It's the fee for service that's after the procedures and the operations that you do, the procedures that you do, that actually makes the money. In fact, everything else is like a loss leader. It doesn't make sense to do it, but you kind of have to do it because then the patients would feel a little suspicious that why are you doing this for free? All right. Large players use primary care as a loss leader for other services. CVS for prescription drugs, Walmart for consumer retail, and Kaiser for surgical services. Yep, I can 100% attest to this. It's hard for companies like One Medical to compete with incumbents that can cross-subsidize primary care with more expensive services. All right. Revenue is fixed by the reimbursement model. All right. Since revenue is mostly fixed by the reimbursement model, tech-enabled primary care became a game of operations optimization rather than quality improvement. Now, again, here what we are talking about is this is very typical of the US market, where reimbursement is the only way in which you get money back, right? But this is not the case all around the world. In fact, like we are seeing a lot of models where this is not true. But let's see whether this applies only to the US or this is an internationally applicable article. So since revenue is mostly fixed by the reimbursement model, tech-enabled primary care became a game of operations optimizing. So there is a fixed pool of patients who you can serve. There is a fixed amount of money that you can make per patient. So it's basically like everything in between, optimize this as much as possible. Some companies like One Medical were able to negotiate favorable fee for service contracts, but others like Carbon struggled. All right. These challenges have resulted in a flight to quality and a flight to gross margin, which ushered in the era of direct primary care, where patients pay a monthly subscription fee to access unlimited care. Okay, cool. So you're basically doing your own insurance, right? So membership-based primary care, Forward, Parsley, MD, VIP. And again, like we've dealt with a lot of these in India as well. We've like worked for some of them. They use our products quite a lot. So to solve for quality whilst maintaining margins, companies like Forward and Parsley emerged, which charged $100 to $200 per month for unlimited care. Okay, so $100 to $200 per month, unlimited care. All right. But still, this is a significant amount. I wonder what an equivalent health insurance rate for this would be. Okay, so consultants would go for over 30 minutes. They're obviously they'll go for over 30 minutes. Clinicians would have patient panels of 600 instead of 3,000, and services like labs were in-house. All right. But at $200 per month, it's hard to acquire and retain patients. They expect a top-notch service that increases costs. Okay, so fine. They expect like the top of everything. Acquisition is harder and retention is harder. It's hard to find a critical mass of patients willing to pay $2,400 per year for just primary care. And again, that is the problem here. Like, it's not that all of their care is free. So if it were, then you would be competing with like broader medical insurance, but this is just primary care. Yeah. So the CACs is again like customer acquisition cost, blew up to over 2,000 at times, making it challenging to scale. So again, this means that you're spending 2,000 to acquire one single customer, right? So, but again, you're making this back, but you make this back in kind of a year. when the customer has finished their year-long subscription, then you get your money back. So whilst high CACs can be justified by strong retention, the problem is that retention was the opposite. If patients didn't receive $100 or $200 of value each month, there was the threat of churn. Again, this is another big issue, right? Like the more often you ask someone to pay, the less likely they are to they're more likely to cancel, because when you ask them to pay every month, they would think every month about, okay, did I get value out of this service? Was this worth it or not? Right? But then if you ask them to pay yearly, I think a lot of companies that we are working with kind of realize that, and then they're like, yearly subscriptions, then the patients only have to think once, which is at the start of the year and again at the start of the next year. So when they think in that timeline, they think about, okay, all of the different encounters and all of the different things that has happened. And it is very likely that there has been multiple nice incidents where they didn't have to spend a lot of money, and then they feel that it's worth the money that they're paying for. Okay. So, I mean, if you're doing this, then, charging every month is a bad idea. Just like get a yearly retainer upfront, right? Margins don't improve much since costs go up. Okay. To acquire customers and reduce churn, these companies had to provide an exceptional service that meant introducing high-cost items like large care team, 24/7 chat, long consults, and consumables such as genetic tests, wearables, and unlimited blood tests. Okay, so it's pretty expensive, and they'll probably like eat through this $100 to $200 in no time. There is an even greater scarcity of high-quality doctors. Costs blew up even further due to the scarcity of high-quality doctors. High-quality doctors were already minting money in private practice. It was challenging and it was expensive to lure them away from, private practice. If they are earning like so much in private practice, why would they come work for a startup? So provider shortages made it challenging to maintain quality with scale. Incentive misalignment. All right. These companies had to battle incentives to have patients visit less to reduce costs versus the incentive to have patients visit them more to improve retention. Okay. The incentives are misaligned because they have to battle. On one hand, the patients ideally should visit them as the least as they can, because the more they visit, the more expensive it is. But on the other hand, you want to improve retention, and the patient wants to, just get all the services they can. It was never about what is best for the patient, and rather it was about what is best for retention and economics. Really good point. Really good points here. After all, if you keep someone healthy, they should hardly need to visit at all. Healthy patients end up cross-subsidizing unhealthy patients and hypochondriacs. So this is interesting, right? Like, because you would think that in a subscription-based system where the patient is paying for their health, they would be incentivized to keep the patients healthy. But then again, what I think there is value in this argument. Like, as a business, as a company, you think about what is best for your bottom line. So that could be retention, that could be your ability to get these patients to recommend you to other people. So it may not always be just keeping the patient healthy. It may be just like optimizing for experiences that retain more than anything else. So this resulted in a game of optimizing perceived value to drive patient retention. Services were staggered over a 6-month initial period to keep members long enough to pay off the customer acquisition cost. Okay. So again, if you want to make profit, you need to at least get back your CAC. Yep. So reimbursement is challenging. The fair value of per member per month fee is closer to $50 than $150. Payers therefore struggle to reimburse this care model. Without payer reimbursement, it was hard to scale since patients could get similar services elsewhere for free. Okay. That said, companies like Parsley did a good job of accessing employee reimbursement by providing a 2x ROI via a 77% reduction in the need for specialists and a 65% reduction in the need for chronic disease medication. Okay, so again, they're trying to estimate, okay, what the fair value of per member per month fee is, right? So payers struggle to reimburse this care model. So it's if you charge something like, I don't know, $200 every month, then payers would just be thinking about, okay, you know what, this is too expensive. I could actually do this better myself. Why should I pay you, a startup who's charging more than that? So ultimately, reimbursement matters in healthcare. Whilst there will always be a small minority willing to pay out of pocket, the majority will take free healthcare over an equivalent paid service. Okay. So this is you're going to get free healthcare in instances where you just want primary care and it's covered by your insurance, it's covered by your policy. Then you would always prefer that over a slightly better paid service that is going to offer maybe arguably better care, but again, we don't know, right? Like, because these companies are operating on like ice thin margins. To solve for both quality and reimbursement, the move was to value-based models, where, in simple terms, companies would make money if they kept patients healthy, and patients would get the service for free via payers. So again, the companies would make money if they kept patients healthy, and patients would get the service for free via payers, be that self-funded employers, Medicare Advantage, or Medicaid. All right. So the move was to, again, value-based model. So this is not any different from the, what do you call it? The full risk models or the capitation-based models, where you have like a HMO or a accountability care organization taking taking the risk of keeping patients healthy and then being paid for that risk. Right. So they'll pay a certain amount per patient. And again, this seems to be in the right direction. Now, let's see what the problem with this is. In-person value-based care. ChenMed, Oak Street, Village MD. Oak Street, all of these pioneered in-person value-based primary care. The value-based payment model rewarded companies for keeping patients healthy. And again, this is what we want at the end of the day. I mean, the reason why we are all doing this is like, let's keep people healthy. Let's like figure out how, what the best incentives to do this is. But let's see what we are talking about. To simplify, the idea was that a company gets paid $1,000 for a patient, and then they bear all the costs associated with the patient's healthcare. Yep, full risk. If they keep the patients healthy, out of hospital and off expensive medications, they pocket the savings. Cool. But if the opposite happens, they bear all the costs. Yes, this is basically the full risk capitation model, explained in simple terms. This dynamic means that value-based care companies see cohort margin expansion over time. Okay. This means that patients who cost $1,000 in 2018 might cost $950 in 2019 and $900 in 2020, and so on. The theory is that costs decrease and margins expand over time as the company gets better and better at caring for its patients. Again, there are two things here. So one is it gets better at actually caring for patients, but the second thing is that you need a critical number of patients before you, again, I think the more number of people you have enrolled in your program, the less chances of you getting this one patient who spends all of your budget, right? So you need a critical mass for this to work. So I think one is better at actually caring for its patients and then spending less. But then the other is you get more people registered, and then the economics of scale also have a play here. Companies use this analysis to justify poor and often negative margins in the present. Okay, free VC money, just like we are at a loss right now, but then if you give us $1 billion, then we would make a profit. So that's basically most healthcare IT startups. Yeah, the kicker is that cohort margin expansion doesn't continue forever. It has an asymptote. I mean, it asymptote I don't know if that's a word, okay, as is the case with all competitive service-led markets. The reason for this is twofold. First, as soon as margins get too large, competition or the government forces margins back down. Okay. For Medicare populations, the government reduces value-based payments if providers are extracting excessive rents. Okay. For commercial populations, competition puts down pressure on margins, and there is no monopolistic scale advantage to offset this. I mean, the one monopolistic scale advantage is the number of people that you have on your plan, right? Like the more people you have, the more margins you can kind of extract. But I do get what he's coming from. Like he's talking about, okay, if you can do it at this margin, there'll be another player who'll do it at an even lower margin, and this is just price to the bottom. You can't. There is no blue ocean here, so to say. There is no way for you to stand out from the crowd. It's going to become a commodity at the end of the day, which is like, okay, value-based care. Are you doing everything right? Are you optimizing for care? And everyone else is going to do the same thing. So, okay, this is just competition dynamics here. So, okay. So, second, the scarcity of high-quality doctors means that it's harder to reduce costs as you take on more patients. Okay. Taking on more patients can increase your average cost of care rather than lowering it. In many respects, healthcare favors boutique, old-school private practices. Now, I would like to see how this changes with AI, right? Like, let's say that AI were to become really, really good, and then you can have really low-quality doctors provide the same level of care as high-quality doctors. Does it change the equation? Right, like does have all of these, so many companies just failed because they did this at like the wrong time. All right, so carrying on. Ultimately, value-based care became a game of optimizing the traditional model of care and gaming the billing coding system. I mean, everybody does this. New care models were unable to drive step function improvements. Expertise remained a scarce resource. It proved challenging to simultaneously solve the trilemma of cost, quality, and access without material care model innovations. That's what led to the AI-powered primary care, which aims to provide always on high-quality care at zero marginal cost. Okay, fine. He's getting there. Okay, cool. I think the thinking pattern is very similar. Okay, so we're getting there. All right. AI, to date, hasn't met Silicon Valley's hype. Again, this was written in 2023. I think this is post ChatGPT, but pre probably like 01, 03. So this is pre models that can think and models that can like properly reason. All right, so let's go to the AI powered one. All right. A large reason for this is that companies have been too obsessed with AI diagnosis, which misses the forest for the trees for several reasons. First, the process of diagnosis takes a minority of a doctor's time. All right, I do agree with this. The majority of it is in history taking, testing, emphasizing, explaining treatment plans, and managing chronic disease. Okay. Second, most consults don't involve patients who are diagnostic odysseys. All right. Most of the time, the doctor knows the correct course of action. And the case which are diagnostic odysseys are the very rare cases in which a statistical AI system is least likely to work. Okay, so they're saying like diagnosis was not the problem to begin with. Like doctors can just do the diagnosis just fine, and the places where the diagnosis is like rare or like you can't get it right, then AI systems are kind of like bad at that anyway. But again, I think this would probably change with the more recent models. I think they are significantly better at understanding the context and understanding what all different diagnoses it could be. And we are seeing a lot of instances where patients have been failed by doctors multiple times just to like input their history into ChatGPT to get their diagnosis back. Like we are seeing this all over the place. Third, AI tools are already become commoditized in care delivery. Okay, again, it's the commoditization and the competition that cuts into your profits here. This is for two reasons. First, the marginal benefit is minimal for the AI startup that is 85% correct versus the incumbent at 80% accuracy. Because AI will be a co-pilot rather than autopilot for the foreseeable future. All right, agreed. Even right now, with all of the advancements, this is still the case. Second, foundation models will likely sit horizontally across healthcare players. These factors mean that distribution will matter more than accuracy. Yep. Okay. So the incumbents already have the distribution sorted. So the startups can't really like displace them. And accuracy, again, if the incumbents just like adopt these technologies, it's kind of going to be the same. As tends to be the case in healthcare, incumbents win. Okay. Where AI is interesting is where it can materially drive care innovation, care delivery innovations versus just being used for diagnostics. Twin Health and Forta are interesting here, albeit not without their own challenges. Okay, I don't know what Twin Health or Forta does. Let's check it out. So, new era of on-chain security. Think probably the wrong one. Maybe they just pivoted and they changed their business model. I don't know. Okay, summing up why nothing has worked. Incremental innovation is commoditized. All right. Cost of building and distributing is just too high. Again, the go-to-market is really hard. Okay. Structurally, the system is not set up for innovation. Okay, let's take a look at this. Median operating margins in the US aren't conducive to risk-taking and innovation, and neither are VC's risk appetites. Okay. The median operating margin for health systems in 2018 was 1.7%. So this was interesting when I was looking at the KP Kaiser Permanente's operating revenue, right? So look at this, like operating revenue is 100.8 billion, operating expenses is 100.5 billion. Like they're operating on like this is razor thin margins, like 0.3% operating income. And this is actually more optimistic. 1.7% is more optimistic, and it's better than the KP's 0.3. Imagine doing 1 billion in revenue and taking home 10 million in profits. These organizations have optimized the crap out of their processes to achieve that 1% margin. There is not much risk you can take on a 1% margin. At the same time, many VCs incentivize incremental innovation. Venture investors de-risk their investments by backing proven strategies that go something like, tell me what population you are targeting, explain who is going to pay for it, show me which large health system you worked at previously. Okay. VCs aim to deploy fast money for safe founders, as if resumes are an investment thesis. Despite evidence that the power law works, investors often prefer predictable outcomes incentivizing proven business models. When was the last time a generational company took that approach? Incrementalism rarely works. Conclusion and what's next? It's hard to change healthcare, but the hard is often what makes things great. This is a nice line. If something was easy, someone would have done it already. Difficulty creates defensibility. Now, it does, but then it could also be that it is just difficult for everyone, and everyone somehow figures out the same thing. But again, that's basically what defensibility and the moat around your business model is. The kingdom easy to conquer is hard to keep. The kingdom hard to conquer is easy to keep. All right. I'm keeping my eyes out for outsiders, working alongside insiders, and thinking about healthcare from first principles. Outsiders bring a fresh perspective, so cool. Just like if you are an outsider, you can break road rules, but you can't break laws of gravity. Well, this was an interesting read. I definitely think there is a lot of value to this, and let me know what you think. Have you had any experience here? Have you tried something out? Do you think primary care innovation doesn't really work? Let me know in the comments below. And again, I'm trying this new screen recorder. I just want to see how this feels and how this works out. Let me know if you like it, or if you just want me to switch to the previous style that I had. I know this one moves around a lot more, but let me know in the comments down below. And as always, thanks for watching.